I see the number plateauing, so I'm going to start. We have 42 participants. Usually goes up over the first few minutes. People wander in just like they used to in the Twig Auditorium. So welcome to Medical Grand Rounds. I think you all by now know what the format is. This is a Zoom webinar format, so only the panelists will have audio and video access. If you have questions, the Q&A is the preferred option. So type in your questions on the Q&A, and I will be looking for those during the course of the talk. Today's Grand Rounds is presented by two folks from our Interventional Radiology group, Dabydeen and John Broder. I think most of you know both of them. Their topic today is a multidisciplinary approach to the management of acute DVT, chronic venous insufficiency, and benign prostatic hyperplasia. Dr. Dabydeen will be the first presenter. So we can start now.
Okay. Thanks. I will be discussing the management and endovascular treatment options for acute DVT and post-thrombotic syndrome. And in particular, I will talk about the subset of patients with DVT that can benefit from treatment that goes beyond anticoagulation alone based on data from recent clinical trials. I will also talk about the management of chronic venous insufficiency, and Dr. Broder will discuss some minimally invasive treatment of BPH with prostate artery embolization. Venous thromboembolic disease is a significant health problem. There are about 600,000 new cases of DVT diagnosed each year in the US, 120,000 cases of PE, leading to 60,000 deaths. An important chronic debilitating consequence of DVT is post-thrombotic syndrome, which develops in approximately 50% of patients with DVT. As you know, once a patient is diagnosed with DVT, the current standard of care is anticoagulation. And anticoagulants work by preventing new clot formation to limit thrombus propagation, recurrence of DVT, but they do not remove the existing thrombus. Patients with DVT have to rely on their body's natural lytic pathways and factors to dissolve the existing clot, and that process can take several months. I mentioned one important complication of DVT is post-thrombotic syndrome, and this typically manifests months to years after a DVT, even with optimal anticoagulation. The clinical manifestations of post-thrombotic syndrome can vary from mild to severe symptoms. Some of the signs and symptoms include intractable swelling, chronic pain, heaviness, or fatigue of the affected leg. Varicose veins may develop, and patients may experience venous claudication. Skin changes like stasis dermatitis may develop, especially around the lower leg and ankle. Thickening of the skin and subcutaneous tissue can occur, known as lipodermatosclerosis. And in severe cases, ulcerations can occur. This can have a significant and lasting impact on quality of life. And nearly 90% of patients are unable to work due to leg symptoms 10 years after an iliofemoral DVT. So is there anything we can do to prevent post-thrombotic syndrome? One important factor is providing optimal anticoagulation. And this is because one of the strong risk factors for post-thrombotic syndrome is ipsilateral DVT recurrence. So by reducing the risk for recurrent DVT, by providing optimal anticoagulation of the appropriate intensity and duration is an important clinical goal. What about elastic compression stockings? Does wearing compression stockings help prevent post-thrombotic syndrome? Compression stockings work by provided graduated compression. They fit more tightly around the feet and ankle and less tightly as you go up the leg. So they essentially help milk blood up the leg, assisting in venous blood flow. In the past, evidence-based consensus guidelines recommended the use of compression stockings for up to 2 years after DVT to prevent post-thrombotic syndrome. And that was based on results from 2 small clinical trials that showed that compression stockings were effective in preventing post-thrombotic syndrome. We now have data from a recent multi-center randomized clinical trial, the SOX trial, which was published in Lancet in 2014, which really showed no benefit of compression stocking versus placebo stockings in the prevention of post-thrombotic syndrome. So based on this data, routine use of compression stocking to prevent post-thrombotic syndrome is not recommended. It is true that patients can derive symptomatic relief from compression stockings, so they can be prescribed for that reason. And that brings me to the role of catheter-directed thrombolysis in the management of acute DVT. That is where we're using lytics and mechanical devices to actively remove thrombus. How can we make an informed, evidence-based decisions on the subset of patients that can benefit from these adjunctive treatments? Now, the hypothesis that it may be beneficial to open the vein in a more aggressive fashion than just relying on the body's natural pathways that will slowly dissolve the clot over time really goes back to our basic understanding of the pathophysiology of post-thrombotic syndrome. There's venous obstruction, which leads to an inflammatory response to thrombus, valve and adjacent vessel wall injury, and valvular reflux. And these things in combination leads to venous hypertension, edema, tissue hypoxia and injury, progressive calf pump dysfunction, and subcutaneous fibrosis, and in severe cases, skin ulceration. So in IR, we can use a number of different catheters and devices to allow for lysis and removal of thrombus from the vein. We can place an infusion catheter, which has multiple side holes, and we can place that directly into the thrombus. And that can allow for the slow delivery of TPA, usually over a 24-hour period. And because the TPA is directly instilled directly into the area of thrombus, the dose and the bleeding risk is markedly reduced compared to if you were to give systemic lytics. If we infuse TPA, the patient is monitored closely in the ICU overnight and is returned the next day to IR, where we clean out any residual thrombus. A common device that we use is illustrated in this animation. This is the angiojet, which can deliver TPA directly into the clot at a low dose, but it could also be used to mechanically disrupt and aspirate the thrombus. This is what we refer to as pharmacomechanical thrombectomy. If the clot is acute and not very extensive, we can sometimes clear it completely in just one session. Now, if patients have a contraindication to anticoagulation, we can still perform these procedures with devices like this and other mechanical devices. We just don't infuse TPA. Now, what is the data to support endovascular management of acute DVT? And how do we select patients for thrombolysis? One of the early clinical trials evaluating the benefit of catheter-directed thrombolysis over anticoagulation alone is the CAVEN study, which was published in Lancet in 2012. And this was a multi-center randomized controlled trial looking at the efficacy and safety of additional catheter-directed thrombolysis with TPA in patients with first-time acute iliofemoral DVT. So the patients included in this study had more proximal thrombus involving the iliac veins and or common femoral vein with or without involvement of the popliteal and femoral vein. What the study showed was a 26% reduction in post-thrombotic syndrome over a 2-year follow-up. There were no deaths, pulmonary embolism, or cerebral hemorrhages related to catheter-directed thrombolysis. But this was a small clinical trial. It included 209 patients, and data from a larger trial was needed to validate these results. The largest trial to date comparing catheter-directed thrombolysis versus anticoagulation is the Attract trial. And this is a randomized, multi-center clinical trial, including 692 patients. And the objective of this study was to determine if the use of adjunctive pharmacomechanical catheter-directed thrombolysis in symptomatic patients with proximal DVT reduced the recurrence of post-thrombotic syndrome over 24 months of follow-up. So the patients that were included in the study were patients with proximal DVT, and that's clot anywhere from the popliteal vein and above. Patients were randomized into catheter-directed therapy versus standard therapy with anticoagulation versus anticoagulation alone. The results of this study was published in New England Journal of Medicine in 2017. And that study showed that catheter-directed thrombolysis did not reduce the incidence of post-thrombotic syndrome compared to anticoagulation alone. 48% of patients experienced post-thrombotic syndrome. There was a higher bleeding risk compared to anticoagulation alone, 1.7 versus 0.3. However, none of the bleeding that occurred was fatal. There was no intracranial hemorrhage. They then did a subgroup analysis and separated out patients based on the location of the thrombus. And in the subgroup of patients with iliofemoral DVT, so more proximal DVT, catheter-directed thrombolysis significantly lowered the severity of post-thrombotic syndrome, early symptoms, and improved quality of life. There was no benefit in patients with femoral popliteal DVT. So what we learned from the Attract trial is that these adjunctive treatments are not for everyone, and that the open vein hypothesis and our basic understanding of the pathophysiology of post-thrombotic syndrome are not the full story. So given the data from the Attract trial, one of the key factors that we consider when we're selecting patients for these adjunctive treatment is the location of the thrombus. Patients with thrombus involving the iliofemoral part of the vein, so common iliac, common femoral vein, can benefit from this procedure. Patients who have clot confined to just the femoral popliteal veins, really they're better off being treated with just anticoagulation alone. Patients with symptomatic CAF DVT can sometimes be treated with anticoagulant. And if they're asymptomatic, one approach is that we can monitor the thrombus for proximal propagation without using anticoagulation. Another important factor in patient selection for catheter-directed thrombolysis is the acuity of the clot. We can get an indication of this based on the duration of symptoms. So if the symptoms are less than 14 days, that's an acute DVT. 15 to 28 days is defined as a subacute DVT, and greater than a month, a chronic DVT. Obviously, patients can have acute on chronic DVT, but in general, the more acute the thrombus, the more likelihood of success. Whenever I'm evaluating a patient for thrombolysis, I basically go through a checklist to determine if there's any contraindications to TPA, whether there's any active bleeding, recent stroke, neurosurgery, or intracranial trauma, recent CPR, major surgery, obstetrical delivery, organ biopsy, major trauma in less than 10 days, intracranial tumor or seizure, recent major GI bleed, or severe thrombocytopenia. The way we perform this procedure is generally the popliteal vein is accessed with ultrasound guidance while the patient is prone. Venography is used to evaluate the extent of the thrombus, and then we pass a guide wire and catheter into this thrombus. And one way we determine the acuity of the thrombus during the procedure, because we don't always get an accurate history from the patient, is this guide wire traversal test. So in general, the easier the guide wire can traverse the clot, the more acute the thrombus is. And the more established and chronic the thrombus is, the more difficult it is to even pass a guide wire through there. We can perform pharmacomechanical thrombolysis to debulk the thrombus, and we may not even need to infuse thrombolytics following this. There are some cases where we do need to place infusion catheters, and like I said, those catheters have multiple side holes that can bathe the clot with lytic agent, and then the patient returns the next day for any removal of any residual thrombus. When we do run lytics, the patients are monitored in the ICU. The doses that we're using are small compared to if systemic lytics are given. Typically, we give about 0.5 milligram of TPA per hour in each leg. So for treating bilateral DVTs over a 24-hour period, we're giving a maximum dose of 24 milligrams of TPA. While we're instilling TPA, patients are on subtherapeutic heparin to minimize bleeding risk with the concomitant TPA. And we may also have them wear compression stockings to activate their calf muscle pump and for symptomatic relief. So here are some case examples. This is a 36-year-old patient who presented with significant left leg pain and edema. Here the popliteal vein was accessed and a venogram was performed. And the venogram showed a patent popliteal vein, but there was extensive filling defect consistent with clot throughout the femoral vein, common femoral vein, and iliac vein. And we performed pharmacomechanical thrombectomy in one session and was able to clear out and reestablish flow in this vein. Lower extremity symptoms. The venogram again showed extensive iliofemoral thrombus and multiple collaterals in the leg. And again, pharmacomechanical thrombectomy was performed with success. There was an iliac stenosis, which was treated with angioplasty and stent placement. This patient had more subacute thrombus that was extensive, which was difficult to clean out in one session. So in this case, we placed an infusion catheter to drip lytics overnight. And the infusion catheter has markers, which denotes the beginning and the end of the side hole. So we can place this catheter directly in the area where there's thrombus and deliver TPA. And then the patient returns the next day for clot removal and stent placement. So I mentioned a few cases where we had patients who had iliac vein stenosis that required angioplasty and stent. And whenever we see a left-sided iliofemoral DVT, we think about May-Thurner syndrome. And May-Thurner is when there's chronic left iliac vein compression secondary to the crossing right common iliac artery. And this chronic microtrauma leads to scarring and subsequent thrombosis. And this is treated, the stenosis and thrombus is treated with angioplasty, stent placement, as well as our pharmacomechanical devices. We don't generally place IVC filters when we do catheter-directed thrombolysis. The patients are well anticoagulated throughout the procedure, and the incidence of clinical PE during catheter-directed thrombolysis doesn't exceed that observed in patients who receive anticoagulation alone. Post-procedure, give therapeutic anticoagulation with heparin. And for the long-term management, we give anticoagulation, antiplatelets for 1 to 3 months if a stent is placed. And that really is operator dependent, whether or not we put patients on antiplatelets after stent placement. And then patients may get a hypercoagulable workup. So I'm going to shift gears now from pathology involving the deep veins of the lower extremity to the other network of veins in the legs that can cause issues when they're not functioning properly. Now, these are the superficial veins, and they reside in the fat layer above the muscle layer of the leg. The great saphenous vein, which runs from the groin to the inner thigh to the inner calf, causes about 70% of the major varicose vein problems in the leg. There are other superficial veins that can be problematic, such as the small saphenous vein, which run on the posterior aspect of the calf. More than 30 million Americans suffer from varicose vein, and the vast majority remain undiagnosed and untreated. And I think this is because there is a general lack of awareness of superficial venous disease. There are also many misconceptions about varicose veins, and some believe incorrectly that this is purely a cosmetic issue and not a significant health problem. In fact, superficial venous disease has a significant physical and emotional impact on patients. It can cause significant symptoms and lead to skin changes and complications such as non-healing ulcers. Leg ulcerations can be debilitating. Approximately 1 million Americans have ulcerations due to superficial venous disease, and approximately 100,000 are disabled because of their condition. The risk of DVT is also 3 times higher in patients with superficial varicosities than in the general population. Here's a schematic of the normal blood flow up the leg towards the heart in one of the primary superficial veins, the great saphenous vein. In a normal, healthy superficial vein, there are valves that prevent blood from flowing backwards or refluxing down the leg. Now, if these valves fail or become incompetent, blood refluxes back down the leg and results in venous congestion. And over time, that pressure builds up in the diseased vein, which becomes enlarged and can sometimes bulge on the skin surface. And we call that condition chronic venous insufficiency. Of note, most of the visible varicose veins are actually tributary veins that branches off from the problematic source superficial veins. In terms of signs of chronic venous insufficiency, patient may experience dull, aching, throbbing pain in the legs, leg heaviness and or fatigue, itching and or burning, leg and ankle swelling, restless legs, Charlie horses or cramping, skin discoloration, and in severe cases, venous ulcers. In terms of signs of chronic venous insufficiency, the outward appearance of the leg may look completely normal, even though we're detecting this abnormal blood flow by ultrasound and the patient is symptomatic. And then other signs may overlap with patients who have post-thrombotic syndrome. They may have varicose veins, they can have skin changes to stasis dermatitis, lipodermatosclerosis, and in severe cases, ulceration. What are the risk factors for chronic venous insufficiency? Family history, genetics play a big role. Pregnancy. This is a progressive disease that gets worse with age. Females are more predisposed. About 50% of women will develop varicose veins in their lifetime. Prior surgery or trauma, and occupations where you're sitting and standing for long periods of time are also a risk factor. The types of visible abnormal veins include these varicose veins. We can also see spider veins, but this is not thought to cause significant symptoms. So treatment of spider veins is considered cosmetic treatment. And there are also these blue reticular veins that are really not thought to cause too much issue. We detect the abnormal flow in the superficial veins with ultrasound. And then we create a vein map like this one, looking at all those superficial veins and plan our treatment. If all the reflux pathways are not properly identified, then the chances of recurrence of venous insufficiency symptoms are high. So what are the treatment modalities for superficial veins? Conservative management with compression stockings can help with symptoms of venous disease. However, compression stockings requires continuous use, and it doesn't address the underlying problem, so other treatments may be needed. In the past, varicose veins were treated with vein stripping, in which the veins were removed surgically. This is now considered obsolete, and in fact, 85 to 95% of patients who've had vein stripping experience recurrence during their lifetime. The reason for this high recurrence is that ultrasound wasn't routinely used to identify and map out these abnormal veins. The standard treatment for varicose veins these days is a minimally invasive procedure called thermal ablation. You can perform radiofrequency ablation or laser ablation. There are other newer techniques to address these veins as well. We use radiofrequency ablation, where we access the vein with ultrasound. We make a small nick in the skin, and we insert a catheter along the vein that we're treated. The end of this catheter has a heating element that basically we use to heat seal this vein. Here's an animation that shows how this procedure is done. We access the vein with ultrasound. We place a small sheath into the vein, and then we place our catheter with the heating element at the end of it along the entire extent of the vein. Once the catheter is in place, we instill what we call tumescent anesthesia. That's basically lidocaine, and that's used for a number of reasons. One, for pain relief. The other is to protect the tissues around the vein. And another reason for the tumescent anesthesia, it increases the contact between the vein and this heating element. So then we start the ablation. We basically heat this vein and seal it off. This vein will eventually scar down completely, and the blood flow will be rerouted into normal, healthy veins, and improving the patient's symptoms and, preventing the progression of venous disease. This is an outpatient procedure that takes about an hour to perform. So the thermal ablation procedure destroys the vein that creates the chronic venous insufficiency by eliminating the problem at its source. We treat those tributary bulging varicosities with a procedure called sclerotherapy, where we inject sclerosant directly into these bulging varicosities under ultrasound guidance and seal those veins off. Now, patients with large bulging varicosities are treated with phlebectomy. We basically map out these bulging large veins with a vein light. We make small nicks along that vein and essentially scoop the vein out from under the skin. Again, this is an outpatient procedure. And here it is, this movie showing the procedure. Again, we do this procedure all under local anesthesia. There's no sedation. Make the small nicks and remove these veins. And this is what we end up with after ambulatory phlebectomy. We basically use a combination of these techniques. We shut down the main problematic source with the ablation. Sclerotherapy is used to treat the medium-sized tributaries that come off that source vein. And the bulging varicosities we typically treat with ambulatory phlebectomy. And patients have significant improvement in their symptoms and the appearance of their legs after this procedure. And we also prevent the progression of their venous disease. Now, some patients can come in with these spider veins. Again, this is not considered medically necessary. This is a cosmetic procedure where we directly inject these veins. Okay, now I'm gonna turn it over to Dr. Broder.
Can we pause for a second?
Oh, yeah,
and
sure.
have a little bit of discussion on this, because the other topic is totally different. So I think the Q&A got some of the questions, but I'm not sure the entire audience heard them. And I think some of those might be good to be discussed verbally. So Dr. Obaji asked, is there a risk of dislodging the iliofemoral clot and causing pulmonary artery embolization? So can you comment on that?
So symptomatic, clinically significant pulmonary embolism during catheter-directed thrombolysis is uncommon. And actually the study showed there's no difference when they compared the patients who had catheter-directed thrombolysis versus just anticoagulation in terms of the risk for PE. And during the procedure, we keep the patients well anticoagulated. So any small thrombus is treated during the procedure, but we don't see clinically significant thrombus during these procedures.
And do you monitor for systemic fibrinolytic state? Do you monitor fibrinogen levels during this?
We actually do not. The reason is we don't monitor fibrinogen levels. The patients are monitored closely in the ICU for major bleeding. The reason we stop monitoring for fibrinogen levels, what we find is that when the fibrinogen levels become abnormal, they shut off the TPA. So basically the patient reclots and we're back to square one. So, I mean, I think a lot of interventionalists that are doing these procedures don't monitor fibrinogen, and we haven't seen any, major issues by not doing that.
Sure. We've seen a couple of cases of mechanical hemolysis in these patients to the point that they even get hemoglobinuria. How common is that in your experience?
I do see it occasionally. I know specifically I had one patient where I used that angiojet, that mechanical device, to disrupt the clot. However, I think it resolves without any issue. So I don't think it becomes a major problem, even though it probably happens more than we know.
Yeah. So there are no reports of renal failure from the hemoglobinuria or anything like that?
No, not that I know of.
Okay.
And again, we do a lot of these and haven't had any major issues with that.
Okay, sounds good.
Okay.
Why don't we move on to Dr. Broder?
Okay, so we are completely switching gears here and moving off the venous system. And I just wanted to take the opportunity to introduce this audience to an emerging procedure that's now being done in interventional radiology for the treatment of benign prostatic hyperplasia. And I thought it'd be useful to introduce you to this topic because we are starting to see some men self-refer for this procedure. So they may be asking about it when they come and see you in the office if they have issues with lower urinary tract symptomatology. So I'm just going to briefly discuss what we do with this procedure, the patient selection, and some of the outcomes. So lower urinary tract symptomatology is a very common problem, and BPH is by far the most common cause. And it's very prevalent in our population. 33% of folks between the ages of 40 to 80 have some degree of lower urinary tract symptoms related to BPH. It has an impact on overall quality of life, costs the medical care system lots of dollars, and there are lots of physician visits. In the year 2000, a case report was published in the Journal of Vascular Interventional Radiology describing a patient who had prostatic artery embolization to treat hematuria related to prostatomegaly, which does occur. And that particular patient, who had significant lower urinary tract symptoms related to the enlarged prostate, developed improvement in their lower urinary tract symptoms. And it was noted that the prostate volume decreased after embolization. So that prompted more exploration into this particular therapy. So animal studies were done, which showed infarction of the gland leading to overall volume decrease and the overall softening of the gland, and an alpha adrenergic denervation of the prostate, also which relaxes the smooth muscle, and then a fibrotic reaction that occurs, which also leads to additional volume decrease. So the other facet in the animal study was that there was no impact on erectile function or sexual desire in these animals. In 2013, the first prospective randomized trial comparing prostatic artery embolization to the most standard therapy for BPH, which is TURP, was published in 2013. I'm going to review that evidence later in the discussion. So what is prostatic artery embolization? How do we do it? We inject small particles directly into the prostatic artery. So the prostatic arterial anatomy can be somewhat complex, but in general, the prostate artery arises off of the anterior division of the internal iliac artery. And this is a diagram showing you the prostatic artery. We're able to place a microcatheter. These microcatheters diameters are now down to 2 French diameter. So they're very, very tiny microcatheters. And we inject small particles into the prostatic artery to devascularize the prostate gland. So during the treatment, you can see these small particles that are being injected, and then post-treatment, the prostate shrinks. We use a similar particle, the same particle, when we do uterine artery embolization for the treatment of symptomatic fibroids. And that procedure has been done now for over 2 decades. This is an MRI showing pre and post. The prostate gland post-embolization has areas of infarction, which are these low signal areas, and the prostatic volume decreases. So in terms of patient selection, most patients need to be placed on medical therapy first, and that consists of the 5-alpha reductase inhibitors, as well as the alpha blockers. And patients that have moderate to severe lower urinary tract symptoms or LUTS refractory to medical treatment for at least 6 months may be a patient who could benefit from a minimally invasive procedure such as prostate artery embolization. All these patients should undergo an International Prostate Symptom Score, IPSS score, which is a gold standard for evaluating the severity of BPH. And also it's a tool that tracks improvement after intervention. The IPSS score includes a question regarding quality of life, which is also a helpful measurement in these folks. So this is the IPPS sheet, which we have our patients fill out, which asks them to self-report their various urinary tract symptoms. And it's scored between 8 and 19 we consider moderate symptomatology. Greater than 19 would be severe, and then less than 8 would be mild. So we want to make sure the patient at least has moderate symptoms to warrant this treatment. We also have to be careful because an enlarged prostate with lower urinary tract symptoms is not always solely due to the enlarged prostate. The patient may have some sort of bladder disorder, neurogenic bladder, or storage issue, which could be leading to their problem. So we want to make sure that we're doing PAE on the right patient. So it needs to be a patient whose symptoms are primarily due to bladder outlet obstruction from the enlarged gland. We also tend to avoid patients that have small prostate glands. The larger the gland, the better candidate for this particular procedure. They should have a current PSA. We want to ensure that we're not treating anybody who has an active prostate cancer. In order to do the embolization procedure, naturally, we have to have patent vasculature. Since this is an older population, many of these patients have significant atherosclerotic disease. So we obtain a pre-procedure CT angiogram or MR angiogram. We prefer CT angiography here to take a look at their vasculature to determine if the vessels look like they can be catheterized, and it really helps us with preoperative planning. So the patient will come for initial consultation, and we'll review their history and medication history, go over their IPSS score, and then we will review the treatment options with the patient, including medical, surgical, such as TURP and PAE. And it's very important that we collaborate with our urology colleagues to determine the best therapy for a patient. So as of now, the patients that we have that we've done have been referred from urology. If and when patients self-refer, we're happy to see them, and then we will encourage them to also consult with their urologist, and we will be working with the urologist to make sure that both us and the urologist agree that this is a reasonable therapy for the patient. So some disadvantages of medical treatment: it's a lifelong treatment, and there may be various side effects, including decreased libido and ejaculation disorders. TURP advantage is the most improvement in prostate volume and reduction in the Qmax, which is a urodynamic measure. Disadvantages of TURP: it requires spinal anesthesia or general anesthesia, hematuria that may require transfusion, short hospital stay, and a Foley catheter. Advantages of prostate artery embolization: it's an outpatient procedure. There's no direct access to the genital tract. There's no risk of retrograde ejaculation, which is one of the potential risks of TURP. Rarely do we have a prolonged Foley catheter. The prostate volume does reduce, and there is significant improvement in both the quality of life score and IPSS score. Disadvantages compared with TURP is there is less reduction in prostate volume and less improvement in the urodynamics. So who's an ideal patient for this procedure? It's really a patient where surgery is not a good option. They may have contraindications to surgery. When I'm talking about surgery, I'm primarily referring to TURP. Some patients will just downright refuse surgery and don't want that option. So this would be an alternative for those folks. And then patients with severe comorbidities, making surgery somewhat risky. Again, failed medical treatment for 6 months or more. Ideally, a large prostate, greater than 80 cc's. Also, folks that have hematuria related to an enlarged prostate would be a good candidate for PAE. And a high IPSS score, greater than 12 ideally, which puts them in the moderate range, but the upper portion of the moderate range. Contraindication would be someone with excessive vessel tortuosity or severe atherosclerosis, where we don't think we can catheterize the vessel, or someone who has mild symptoms. Other contraindications would be active infection, cancer, someone with primarily a neurogenic bladder, an atonic bladder, or urinary obstruction due to another cause besides BPH. So I'm just going to show you a couple examples. So we can access the arterial tree either through femoral access or radial access. We're now doing more and more procedures via radial access. And the technology has evolved such that we have very long catheters and long devices now that can reach deep into the pelvis, even from the wrist. So many patients prefer radial access. I'm not going to review the anatomy for this particular audience. One important portion of the procedure is there are collateral circulation with the prostate gland. And we need to recognize those collaterals to avoid what we call non-target embolization, which are the particles going to a vascular territory that we don't want them to. So there are collaterals that can occur with both the bladder, the rectum, or the penis. So we use a technique called cone beam CT during the procedure, which is helpful in avoiding non-target embolization. I have an example of that shortly. Microcatheter technique is a must. These vessels are very prone to vasospasm, so we need a very, very small diameter catheter in order to do this safely and effectively. And we embolize with 300 to 500 micron sized particles. Some providers use 100 to 300 micron particles. There are pros and cons to the various size particles. And again, we have to avoid non-target embolization. So this is an example of a patient with a large prostate who we did. This is an angiogram of the left internal iliac artery. And this little vessel here is going to be the prostatic artery. So we get a microcatheter in that vessel, and this is a selective catheterization of the prostatic artery. And it's fairly hypervascular, and we have our parent catheter, which is a 5 French catheter, sitting in the proximal internal iliac, and then thread the microcatheter down into the prostatic artery. Post-embolization, after we have injected the particles, play a little slower. You can see that the gland is now devascularized, so there's no filling of those small branches. In contrast, is refluxing proximally. This branch here feeds the bladder, so you can see how there are some collateral vessels that could cause the non-target embolization. So we watch for that as we do the embolization. And then we do the contralateral side. So that's the internal iliac, anterior division, selective prostate. So this is a prostatic artery. And then post-embolization, you see that it's devascularized. Another patient I did. So left internal iliac, oops, back up there. Selective catheterization of the gland. Okay, so here's a prostatic artery here. So we're in the prostatic artery. And then this is a patient that we did cone beam CT. And what cone beam CT is while they're right in the angio suite, the X-ray beam and the image intensifier rotate 180 degrees around the patient. And we get a volume of imaging data, which the software then manipulates into CT images. So this is what we're able to see now on table. We get essentially a CAT scan of the patient while we inject contrast. The spatial resolution isn't as good as a typical CT, but it gives us the information that we need. So this is a coronal image after we inject into the gland. And what I want to demonstrate is the enhancement of the prostate. So we can see that the prostate is lighting up here with contrast material. So we know we're in the vessel, and we don't see any significant enhancement outside of the gland, so we can safely embolize this prostate. We get this multiplanar. That was coronal. This is axial. My video is acting up a little bit here. I'll just breeze through this. Axial plane as we come down into the gland. Again, here, so the patient has a Foley catheter. We put a little bit of contrast in the Foley balloon so we know exactly where the bladder is. This is the prostate gland, which is enhancing avidly as we're directly into the prostatic artery. So that's cone beam CT. We are using this technology routinely when we're doing liver-directed therapy for folks that have metastatic disease to the liver or primary liver tumors that we're treating with liver-directed therapy. It helps us make sure we identify the vascular supply to those particular tumors and effectively treat them. Okay, so on this gentleman, I was able to embolize the left prostate. I could not catheterize this right prostate. As I said, some of these patients have very difficult anatomy. So you can see I attempted to catheterize this prostatic artery, and I could not get the microcatheter to go beyond this area of calcific plaque. And you can see how small these vessels are. So there will be some folks that we unfortunately can't do both sides of the gland. There is some benefit to do a unilateral embolization, but ideally we want to do a bilateral embolization. Post-procedure, patients may experience what we call post-embolization syndrome, which is treated with various medications, antibiotic, anti-inflammatory, analgesics. So we will monitor the patient for post-PAE syndrome and treat them accordingly. The most common issue is burning with urination and some mild pain. Patients may have some bladder spasm. So we may have some hematuria, even possibly some, if we had any rectal ischemia, there could be some mild bleeding in the stool as well. So this may occur for 5 to 7 days, but patients go back to essentially normal activity after several days. It's a safe procedure. There are potential complications. A meta-analysis was done in 2016, which looked at 662 patients, and the major complication rate was under 1%. The benefit of prostatic artery embolization can occur as soon as 2 weeks post-procedure. The peak benefit, it begins at 3 to 6 months. Patients that are catheter dependent may be able to become catheter independent, and they can attempt avoiding trial as soon as 2 weeks after the procedure. Outcomes. So there has been a fair amount of data published in the literature. A study of 630 patients showed that the 12-month improvement in the IPSS score by a mean of 13.7. So that's a significant reduction in the IPSS score. If you remember, the moderate range was 8 to 19. So 13 points is significant. And this was sustained at 1 to 3 years and even out to greater than 5 years. In the UK, they did what was called the ROPE study, which was a comparative trial between PAE and TURP. And at 12 months, the improvement in the PAE group with the IPSS score was 10.9, and that in the TURP group was 15.2. So both had significant improvement, TURP more so than PAE, but nevertheless, still a significant reduction with prostatic artery embolization. A study by Gao et al., 114 patients, also compared TURP to PAE. TURP showed more improvement early on and equivalent with PAE at 6, 12, and 24 months. There was also the UK ROPE study showed improvement in the quality of life score in both cohorts. Okay, so in general, prostatic volume and post-forward residual is improved with both PAE and TURP, but favors TURP in terms of the reduction. The treatment-related adverse events were less frequent with PAE compared with TURP. So current guidelines in the UK, it is now reimbursed by the UK National Health Service and considered safe and efficacious procedure. And so the UK now supports using this in treatment of BPH. In the United States, the FDA has approved the particles specifically for PAE. The American Urological Association guidelines still considers PAE outside to be part of it, should be done in the context of a clinical trial and this is based on expert opinion. There's some controversy as to whether that is more of a political statement, but by the AUA. But as of now, that's their standard guideline. In 2019, Society of Interventional Radiology put out a multi-society consensus position statement on this procedure, and I'm going to finish with the reading the bullet points for this consensus statement. That this procedure is an acceptable, minimally invasive treatment option for appropriately selected men with BPH and moderate to severe LUTS. PAE can be considered as a treatment option in patients with BPH and moderate to severe LUTS who have very large prostate glands. So occasionally the prostates are so large that the TURP is ineffective, or patients may require a suprapubic prostatectomy. So this can be a procedure that can help those particular patients. There's no upper limit of prostate size. PAE can be considered as a treatment option in patients with BPH and acute or chronic urinary retention in the setting of preserved bladder function as a method of achieving catheter independence. So again, we can achieve catheter independence in these patients. This can be a treatment option in patients with BPH and moderate to severe LUTS who wish to preserve erectile and/or ejaculatory function. PAE can be used in patients with hematuria of prostatic origin. Patients who are poor surgical candidates, this is a good option for them. That's what bullet point 6 says in summary. PAE should be included in the individualized patient-centered discussion regarding treatment options for BPH with LUTS. And finally, interventional radiologists, given our knowledge of vascular anatomy and use of microcatheters, are the specialists best suited for the performance of PAE. Thank you. So again, you may have some men that may start to inquire about this. I would encourage them to visit their urologist and discuss all their options, including PAE.
Thank you. As I get older, there's a question on the Q&A. Dr. Chaudhary asks,
You're breaking up, Brad. I'm sorry, I'm having a hard time hearing.
Yeah, urolift evaporation enucleation. Can you comment on that?
On urolift, to be honest, I don't know a lot about urolift, so I'm not going to comment on urolift. I don't know if Danette has any comment on that. I know that's another technique to treat BPH that the urologists are starting to use, but I don't have a lot of knowledge on that specific procedure.
Not seeing any other questions, and we're just about out of time. So thank you both. That was great.
Thanks for the opportunity.
Oh, I see one more. I see one more pop up. Effect of contrast on renal function.
So naturally, there's data that suggests that one can have contrast-induced nephrotoxicity. We will certainly check the creatinine in these patients. And we're able to do these procedures with a fairly low volume of contrast. And with good IV hydration, we can limit that risk. But naturally, if someone has severe renal insufficiency, that may be a potential contraindication.
It's not a huge contrast load though, right?
Ideally, no.
Yeah.
Sometimes you run into situations where you end up using more contrast than you would like. But.
Yeah. All right. Thank you very much. I'm going to stop the recording. You had 88 people at the peak, and it got lower toward the end. So.